Hey, welcome everyone to the 6th Annual Parent Network Workshop. We are pleased to have you join us for Beginning with the End in Mind, Transitions Back from Out-of-Home Treatment. Before we get started, there are just a few housekeeping items. If you have questions during the session, please use the Q&A feature that is located in the Zoom bar. And in the coming days, this session will be, it is being recorded and it will be posted on the Parent Network website. So go ahead and look for it at idahoparentnetwork.org and definitely share it with any friends, families, or providers that you feel might benefit from it. With that out of the way, I would like you to join me as we talk with Gail Baker from Optum, Francesca Barbaro from Medicaid, Liza Crook from the Idaho Department of Juvenile Corrections, Darren Henderson, who is at Teton Peaks at the Behavioral Health Center here in Idaho, Melissa Hultberg, who is also from the Idaho Department of Juvenile Corrections, Rena Lingelbach, who is from Optum, myself, and Amy and Trisha are both having technical issues, so we may not see them today. So we're excited to have this conversation about transitioning home. And today we are specifically going to learn about two different systems where kids receive out-of-home mental health care. And we are specifically not talking about foster care in this presentation. So just so that you are aware, understanding why transitions home are discussed at the beginning of care and knowing how to gather your transition team. So that's really what we're talking about today. To get us started, I just wanted to talk a little bit about why we call it transition planning and not discharge planning, which is a very common term that has been used for a long time. And you'll see in Idaho that you're going to see the term transition planning a lot more frequently. And that is mainly because as parents, we gave feedback to the state agencies that said the word discharge is very uncomfortable for us, very uncomfortable. Discharge kind of, I mean, the joke is discharge is something that probably needs a gauze pad and medical attention, but it's not something we do to our children. When the word discharge is used on the day that our child starts treatment, as a parent, we very frequently feel like our job is now to prove why they need to stay. And that the rest of treatment or the rest of the time that our child is with a facility or with a placement, we are very focused on proving to everyone that they don't need to discharge yet. But when we use the word transition, we are signifying that we know that this placement is not forever, and we want to make sure that those kids, and our kids specifically, is transitioned back to a community environment. So we're going to pass this over to Francesca from Medicaid to get us started, kind of explaining the path. But that's why the word transition is being used in Idaho more frequently now than discharge.
Awesome. Thanks so much, Laura. So as Laura mentioned, when it comes to the community placement, the community kind of path in getting to myself and my team, through EPSDT, which is early and periodic screening, diagnostic, and treatment. We see most of our youth that come our way are receiving referrals from, well, we are receiving referrals from the community providers. So typically primary care physicians, psychiatrists, psychologists, folks who are kind of on the front lines with these youth and families. They're identifying a need for the residential level of care, and specifically that PRTF, the psychiatric residential treatment. Once we receive those referrals, we are then kind of put into our practice of taking the steps necessary to determine if that youth is going to meet the criteria for medical necessity for a PRTF. Of course, since this is about the transition planning and helping families and youth to safely and effectively transition back home, I think it's important to note that my team, whether it be one of our frontline program specialists, who many of you have probably been in contact with if you've submitted applications, or our team of clinicians, we work with the families and the youth throughout the entire time that individual, that kiddo, is in treatment at a PRTF. So that entails attending monthly, if not in some cases weekly, treatment team meetings so that we are discussing the transition plans from the start. So our hope, our intention is truly that when a youth admits into a PRTF, that we're beginning to discuss what that transition plan might look like, knowing that things change. And, treatment is fluid, treatment planning is fluid. So we're always open to really looking at what things are going to look like towards the end. Obviously it changes, but our intention is that we're starting these discussions from the get-go so that families are, if possible, not put in a position of towards the end saying, whoa, why are we all of a sudden talking about this transition plan when it hasn't come up at any other time throughout treatment? So again, really important to note that we are able to, fortunately, stay involved with these youth throughout their time in a PRTF. We work very closely with our partners in determining what that transition plan is going to look like. So, my team could not do it without the Optum FCCs, the Children's Mental Health team, the FACS team, all of our partners that help in assisting with identifying those outpatient services, but also potential step down options.
So Francesca, you just rattled off a long list of acronyms. So
What should we go back to?
FCC, Field Care Coordinator, which is a position at Optum. Then FACS, Family and Community Services, as part of the Department of Health and Welfare.
Yep.
And let's see, how many others did we roll off? CMH, so Children's Mental Health is CMH. If we go back and forth, did I miss any of the acronyms? We're good at acronyms, aren't we? We're really good at them.
Yeah, we are. I think that was it. I think those were all the acronyms. So awesome. So
I did want to point out that you mentioned children's mental health. And for those families who have an open children's mental health case before they go to a residential placement, very often the children's mental health team steps back until we are closer to transitioning home. So it fluctuates based on the kiddo and the case. But if a family wants their children's mental health clinician to stay involved, they need to make that request.
Yes. Awesome. And that is something that I just to add to that, Laura, as we are working with families and youth while that individual is in a psychiatric residential treatment facility, we do our best to be asking questions throughout the course of treatment to understand what partners have been involved in that youth's care when they were in the community. We will coordinate as often as possible and collaborate with those partners so that we can really identify if someone has been closed with children's mental health, let's say, they are able to be brought back in early enough into treatment that, like I had mentioned, it's not, being done at the very last second. So I would say as long as there's communication going on, we're able to do our best with trying to create a smooth transition plan as much as possible. So
definitely. So our folks from Juvenile Corrections or Juvenile Justice, sorry, Idaho Department of Juvenile Corrections. Can you talk to me about your side of this of the chart?
Sure. Thanks for having us, Laura, and good morning to everyone. So she just defined IDJC for you. So it's the Idaho Department of Juvenile Corrections. I'll be referring to it as IDJC throughout the presentation. So hopefully that's okay. I'll try really hard not to do acronyms, but it's pretty difficult with our lingo. Let's get started. So I guess with the juvenile justice system, I'd like to just kind of take one step before this slide presents. I kind of wanted to talk a little bit about the adjudication process. A client would or a youth would commit a crime and then go through the adjudication process within the court system. And then they would potentially be put on probation. And at that time, during the probation period or the evaluation period, probation, the court system, providers, anybody that's involved, the family, of course, will be kind of have services coordinated around them. We're going to try to maximize every potential to keep them in the community and to be able to provide those mental health services from their home community. We always try, when I say we, I'm referring to the juvenile justice system, is strongly advocating to keep those youth in their communities so that they can prevent commitment into the Department of Juvenile Corrections.
And Liza, the reason we titled this slide Juvenile Justice is I think it's important for families to know that IDJC is not in charge of a majority of what the kids do. And so most of it is local and county juvenile interaction. Probation is usually county, and you might have local or county law enforcement involved, county courts. And IDJC doesn't touch it until we hit that level of commitment. And I think another word you use that most families won't know is adjudication.
Okay.
That's a word I didn't know until I started this process. But that's why when families hear the word juvenile justice and they don't know what part IDJC plays in it. So I just want to make sure everyone understood that you guys actually don't touch it until the end of the line. You're not involved in the arrest. You're not involved in county detention. You have programs that help those families, but you're not the lead agency, for lack of a better term, until a judge puts a child in the custody of IDJC. So for families who didn't understand that, I just want to make sure they understood that. And then I'll let you define adjudication, because that word to me requires interpretive dance to explain.
So another word that you could refer to is sentencing. So it's when a client and their family are presented to the court system and they need to evaluate the crime. They need to work with the prosecutors to determine if the client is going to be charged to go to the next step. Well, that be probation, or they go on another pathway to maybe the Department of Juvenile Corrections for commitment. So it's just that whole court process. And I think a really good resource to mention right here and to kind of plug is the parent handbook that was rewritten recently. It has a great amount of information on that whole process, what sentencing or adjudication and all those terms can mean as it relates to the family and the youth. So that would be a really good resource for someone to reach out to if they're confused within the juvenile justice system. I hope that helps a little bit more. IDJC does have a little bit of with the community-based piece of it, with some programs that we have, which I'll go into more detail later on in the presentation. And they're called the Community-Based Alternative Services Program and the Substance Use Disorder Program. And really, in a nutshell, what those are some funding that we can provide to probation so they can access additional resources that they maybe wouldn't have covered through Medicaid or private insurance, or maybe they don't have insurance at all. So that allows for probation to find another funding resource to get mental health or substance abuse or whatever the service need may be put in place and funded for those families. So once a client kind of goes through that process, and we're trying really hard to wrap around as many services as we can, if they're unsuccessful or they just go straight to that hearing where they're being committed to the Department of Juvenile Corrections, a Rule 19 will be will basically be put in place. It's a meeting that's had between all the stakeholders where all the parents and the youth attend, and they determine if commitment is the best pathway. At that time, they take that information back to the judge, and the judge determines the next step. If they are committed to the Department of Juvenile Corrections, they're put into an observation and assessment process where a mental health or a treatment plan is completed if needed. And that's where, from that evaluation, they do kind of the next steps, where they're going to be placed, where they're going to be housed, what are the needs of the client, is a private facility going to be needed, things like that. So that's kind of that. I'm just kind of giving you a synapse of it because we're going to go into detail later on in the presentation. So I don't want to go on and on, but hopefully that kind of gives you an idea, a gateway into the Department of Juvenile Corrections.
I think it's really important to mention that IDJC is not actually meant to be a mental health treatment facility. I think, unfortunately, parents are told, oh, just, have your kid get arrested and then IDJC will treat them. That's not actually what you guys do. You're not a court-ordered mental health facility, though you do work with kids who have mental health concerns. Is that an accurate way to put that?
Absolutely. Of course, mental health is common in the juvenile justice system, mental health or substance abuse or co-occurring disorders. So the Department of Juvenile Corrections is going to serve them and based on that assessment, and then provide them the treatment that is needed to help them rehabilitate the whole time that they're committed to the Department of Juvenile Corrections.
And I do think it's important to also point out that IDJC does work really hard to bring the right stakeholders to the table throughout the process and throughout commitment, so that it's not a surprise to anyone when the child goes home and what that looks like. So that combination of that treatment team bringing it home, though you guys call it, you have a special word for your team. What is it? Your juvenile service coordinator, right? JSC.
Yep, we have a juvenile service coordinator that's assigned to every youth. We also work on reintegration plans right from the beginning, and Melissa will go into detail in that in a bit. So there's a lot of transitioning planning right from the start. The juvenile service coordinators are involved through that whole time, and they have that one-on-one client and family engagement to help support them through the process.
All right, so this is another system that we start transitioning home from the day we get there. And so that's what we all have very much in common. Okay, well, so when we talk about the two different systems, we want to kind of talk about their similarities and their differences as we go through. So we're going to kind of give a visual, a graphic moving forward, talking about the similarities and the differences here. And so right now I'm going to pass this over to Darren, because Darren works at a residential treatment facility that is a regular PRTF, a psychiatric residential treatment facility. So Darren.
Thank you, Laura. I guess I wanted to start by discussing a little bit about what residential treatment really is. That's one of the biggest questions parents ask is, what are we getting into? What does that mean? And so from day one, parents or guardians or caseworkers, they're involved in the very first step, which is when we bring a youth in gathering all the information and then developing a care plan or / treatment plan. And as part of that care plan, there's a transition plan as well. We're already identifying, what services this young person might need in the community. But I often have to, let parents know that there's really 3 steps to residential treatment. And the first step is, bringing the youth in, developing the care plan, but really evaluating how skillful this young person is. Do they already have some coping skills that they've, been trying to use? Because the meat of residential treatment is we want to dig in and really find out what's going on with this young person. Is there trauma? Or what issues need to be addressed in treatment. And then once that's established and we can see that they're skillful and maybe we do some more skills training, that's when we dig in to do trauma work or family work that needs to be done to help a person. And that's the second step in residential treatment. And then as working on those issues, the main issues, we then kind of transition into step 3, all the while doing staffings with our treatment team, as well as caseworkers and parents along the way, identifying where their child is in that stage of treatment. Step 3 is about, transitioning. It's about seeing that they can consistently cope with the hard stuff that they've just worked through. And as they have shown that they can cope and deal with these things, we're working with families to transition them to the community. So a lot of time.
Darren, I've heard step 3 referred to as peeling back the layers of the onion. That it is, you go in for one thing
Mhm.
And then as you start treatment, there's like, oh, and then there's this other thing.
Right.
Oh, and this other thing
Yeah.
that you may not have known about when you first started. And that's part of
Right.
the process. I think families should not be surprised when the
Right.
original treatment goal is one thing, but as time goes on, they learn more and more. And all of a sudden,
Right.
maybe we thought this is what we were doing, but oh, now we're over here before we go back to that.
Right, right. Oftentimes we think we're in step 3 and we're kind of working through, and something does come up, like you said. And then so then we have kind of a step back to that step 2 again, and dig into whatever that problem or issue is. And oftentimes that's when trauma is introduced, because that normally isn't the core issue when they come in. It's usually mood instability, or difficulty managing emotions, whatever. And then, lots of other issues come up. And that's oftentimes when, some of the family issues come up as well. And we, kind of dig into and do even more family therapy if needed. And then, as we are able to work through those issues and see that, okay, we are ready to transition to home, that's when we start looking at what is the best step down for this person. Oftentimes we look at a PHP, or partial hospitalization program. Some people may call it day treatment. The issue with that is a lot of communities don't have that. They can't offer that. And so we may look at an IOP, which is an intensive outpatient program, where a young person might go for 2 or 3 hours, 3 days a week, and do groups and different things.
Well, I think what you said is really, really important, because I know that when I have had a child in a residential treatment facility, and the facility called and said, okay, we're getting ready, I think we've got a great transition plan. And then they started listing off a whole bunch of things that Idaho doesn't have.
Right.
And I went, well, we don't have those things. And they said, well, can you get access to them? I'm like, no, they don't exist. It's not
Right.
it's not that I didn't call. It's that they're not here. Or that program is in Idaho, but it's 4 hours away from my house, and it's a daily program. I can't drive them 8 hours every day for a 5-hour program. And then, so that means that maybe we're not ready to come home yet if that level of care doesn't exist. And we may need to work on more things to get them ready for a level of care that does exist in your community. And it also means that if the wait list for that is 3 months long, we need to identify it soon enough that we can contact that provider or that program and see if we can get on the wait list for when we are coming home. So I think that step can never be underemphasized, because that's really when we set ourselves up for success, is identifying those community supports we're going to need. So if I had gold stars and flashing lights, it would go on that step.
Yeah, and the reality is we're identifying that in the first days of treatment. Where do they live? What does their community offer? And so we should know within the first week kind of an idea of what a step down might look like. And so we've even had, kids sometimes discharged to a grandparent or something, because it did offer something that maybe that didn't offer in their parents' home. And doesn't happen very often, but sometimes we have to look at that and what's best for the child in that moment.
We did that in our family. We discharged to a relative who had more resources in their community. And it was a very intentional thing, but it required a lot of coordination. It's not the expected results, but it was the right step at the time.
Yeah. So that's kind of the process, and we don't discharge without a plan. There's we oftentimes do involve children's mental health, and Optum is helpful sometimes, and other aspects of helping plan, because they may have some resources that I don't have in discharge planning as well, or transition planning.
Thank you.
So I think that's all I have on that.
Yeah, I think that pretty much covers it. So let's go talk about now what it looks like on the juvenile justice side.
Okay. As Liza mentioned earlier, this is, the youth have to be committed to the Department of Juvenile Corrections. So it's a court order commitment. So it's not voluntary. And they get an indeterminate type of sentencing. And what that means is that the youth have to complete their treatment before they're released from our custody. Obviously, we want our the youth to get through program as quickly as possible because we recognize that they've been separated from their families, and that in itself can be traumatic. However, DJC, one of their main focuses or goals is the family engagement process. So as a juvenile is committed to the department, they're assigned a juvenile service coordinator or a JSC. They are a case manager, licensed social workers who work with the juvenile and the family. They contact the family immediately and start that engagement process. Another key player is probation. Probation is a lot of time these kids who come into our care have already been on probation. We've had some that have not. But the probation officer and the family act as a great resource for the department. So we start collaborating and partnering immediately out of the gate. That includes the juvenile service coordinator working with the family on what we call a reintegration plan. Everyone's on here saying transition plan, but we refer to it as reintegration plans. So we also get input from the probation officer at the same time, because again, the goal is to be collaborative and partner with our communities. Once the kid is committed and they're going to go through an observation and assessment. So that's a key point in the commitment process. We want to make sure we're identifying the needs of the juvenile immediately. That sometimes is mental health. And we treat the whole person. So we want to make sure when developing the treatment plan, which up here on step 3 is a service implementation plan is what we call it, the SIP. We are including mental health treatment if it is a need. Again, we're getting input from the family during that process and probation. So let's see here. Once the service implementation plan is finalized, or I mean, when it's completed, that is like the foundation for the treatment for a juvenile, and it does not change. However, the reintegration plan is attached to the service implementation plan, and that is fluid. It will be addressed monthly. The juveniles have monthly staffings with their treatment provider. Families are included, probation's included. So we update basically the reintegration plan. So we're talking about transition planning, reintegration planning every single month with the family and make changes as needed. So as release date nears, when we're probably about 90 days out from release, the JSC is including any sort of community supports. We often talk to the families about any sort of supports that they may have had in the community that has been helpful to them. But also we look at making referrals, anything to help with the transition, help the family specifically, maybe just working with them in the community. And then we've used like family preservation services before. And back in the day, there was functional family therapy. I don't know if very many people remember that. That was FFT. But preservation services, sometimes when we recognize that the family is struggling and may be a little nervous about the juvenile returning home, we will pay for family preservation services to be working with that family and preparing for, let's say, Johnny to return home. At the same time, during the monthly staffings, if we have outside agencies or any sort of supports to help with that transition, in probably the last 60 days, which would be the last 2 staffings, we would want those providers to be involved in those staffings. So again, we're partnering, we're collaborating. anything to help support this transition. Let's see, after the planning is finalized, the ideal goal is to have the aftercare plan finalized probably 30 days prior to release. Realistically, that doesn't always happen, but that is a goal. We recognize that life happens. Sometimes, you know, families may change their mind at the last minute due to certain circumstances, but ultimately we're continuing to communicate and talk with the family and checking in with the family and have this goal of having a plan finalized. After all of that is done, the juveniles, majority of them, it differs county to county, depending on what county they were committed. Majority of juveniles go to what's called a return to community hearing. So that is where the juveniles are back at court. They are sharing with the judge what they've learned. DJC's there talking about the aftercare plan, maybe any barriers. Definitely want to talk about success. And so that's also a time, even though probation's been involved, but at that hearing, we pass what we call kind of the baton off to probation. And then they continue with the juvenile in the community on any form of probation terms that have been set. So for number 6, I'm going to pass it off to Liza because I know she wanted to talk a little bit about some community-based resources.
Thanks, Melissa. Before we jump into that, could you talk a little bit about a scenario when a client would be placed under IDJC's oversight, but they're being placed in a different facility? It's very rare, but when it happens, you know, like, so say we go through an observation and assessment process and the youth is determined to have a need that DJC can't fulfill.
Right.
What happens then?
So you're referring to like a contract placement.
Yeah.
We have utilized contract placements before, more so in the past. Let's say we have a juvenile that maybe does have some strong mental health that was committed to us or is developmentally delayed. We will contract with a program such as, let's say, let me use an example of, we've contracted with Benchmark before in Utah. And it's very similar process. The JSC plays a key role in, again, having that communication with the program, probably the therapist there. Again, just working closely with the program. It's not much different than a facility. We've had some pushback on contract placements before, maybe wanting to keep kids a little longer than what we felt was needed, but we would just have to work process and analyze a plan.
They just wanted to make sure, because they mentioned it in a previous slide, that sometimes some of our youth go to out of placement, like DJC placement, and go to those facilities. So I appreciate you covering that.
Yeah.
So I kind of wanted to pick back up from when she mentioned the baton handing to probation, and I kind of referenced that when I was rambling on earlier. So once probation has them back in the county, sometimes those clients frequently need mental health support. So probation will ultimately work with whatever the funding source is associated to the family. So say they had private insurance or they had Medicaid, they'd go through those open doors or those gateways to try to access those funding services to get coverage for the mental health treatment that they're looking for or needing for the youth. But it happens, when Medicaid doesn't have a service or a service that's needed for the youth that they don't cover, or the family doesn't have insurance. And so that's where DJC comes into the community funding that we have available for probation to access on behalf of the family. So they can reach out to us and request that funding for whatever service they're looking for. And we're able to reimburse the providers directly so that the cost does not fall onto the family. So it's a huge thing for probation to have this resource, including the family, because we want to make sure that the clients are as successful as possible. And if the funding is not in place to receive the services, we're going to kind of break the baton, if you will, and the client, could potentially relapse or struggle in a different way. And so I just like to mention those resources that we have. And so those are community-based alternative services program and the substance use disorder program. And a couple examples I'll throw out would include things like maybe an intensive mentoring, or behavioral addiction therapies or sex offender treatment. Those are a couple different services that we're frequently paying for clients that are coming out into the community from the Department of Juvenile Corrections that need to have that continuation of service. So that's just one example that I wanted to throw out.
Thank you, guys. You guys have, I mean, IDJC does a really good job of bringing those teams together as part of its creation. And I think the EPSDT process with Medicaid has come a long way in probably the last year and a half of really doing a great job of that teaming on the backside. The question kind of came in, how have things changed since the implementation of youth empowerment services? And I'm sure everyone has their own opinion on that, but I would say that the teaming process is more formalized than it was before. And while we're still struggling on getting all of the services that we would like to have, I'm sure everyone at this table would love to have more services available to our kids. But I think that it's the teaming process of everyone understanding they need to be at the table that has been different since the youth empowerment services. Also, the timelines that we use. I know IDJC, we've had lots of conversations with your staff about starting sooner with our mental health kiddos, making sure that we have time to connect them to community resources. And with EPSDT, I think it's also been a much, this is just from my experience, there's been a lot more conversation about that what happens next. This is not the end. This is just the step before the next step. And what does that next one look like? So I wanted to quickly go on, and we need to talk about what does it look like of creating that team that I just alluded to. We have teams are a little bit different and we are running a little bit behind. So let's make sure we hit this. This is so important, but I want to make sure that we talk about what it looks like to be on our basic teams. And I want to start with a quick caveat that teaming is every family and every child is going to look a little different. So if you look at the two charts there, a community placement transition team, and when I say community placement, I mean, maybe we should have said voluntary, but it's not always through Medicaid. It's sometimes Children's Mental Health can help with the placement to a residential facility. And sometimes private insurance does, honestly. There's different ways to get to a residential treatment facility. But we need to have the right people at the right table from the beginning. It's really hard to bring someone onto the team that has no idea of the history of how we got here or why we've made the decisions we have. And then at the very end say, okay, now we need you here to support this. And, well, why didn't you do this? And why didn't you do that? It's kind of a step back process. So we have to make sure that we bring the right people to the team. So when we talk about facility staff, we're obviously talking about the staff that is in the facility right there, that's not in our home. And then the local providers really are the people that we're handing it off to, who need to be at the table to make sure that we have the right providers, the right people. Sometimes that is someone you already have a relationship with, but it could be someone new for a need that was identified while in treatment. A case manager, we have a little asterisk there because not everything was going to fit in the cute little box, but with the support of a field care coordinator. So, and we'll talk a little bit about what field care coordinators are in just a second, but they are part of the Optum team to help families identify services in their communities. Agency staff, I've lumped that in with all people who work with a .gov email extension. And that's really going to be the people that need to bring to the team, whether that's Children's Mental Health or that's Medicaid, or if you have family and community services involvement in your family, that would all be there. And then parents and guardians. I guess we probably should have talked about parents and guardians and advocates possibly right at the very beginning. But, and I want to make sure they understand that advocates are, a parent and or guardian can invite someone to this treatment team meeting at their discretion at any time. So if that's a friend, if that's a family member, if that's someone from an advocacy organization or someone who's walked this path before, that it is always okay for a parent to really have someone who helps support them. Sometimes an advocate's job is just to listen to make sure all the questions got answered in the middle of a big meeting. Sometimes the advocate's role is to stop and say, let's pause here. I think we missed something important. Can we go back? Every family will use an advocate a little different, and it's at the family's discretion, but they can be, I guess, a very important part of that team. So we want to make sure that we notice at the very center is the youth. This is not a plan about what's great for adults. This is not a plan about what is fabulous for mom or dad or the agency. It's a plan about what is the right decisions for the youth. And while we would all like there to be more options in our community in Idaho, it's the best we can do with what we have. I wish I could say that it was fairies and unicorns, but it's the best we can do with what we have, focused on that specific youth at that time, which means a transition plan for my child is going to look different than your child. And that's okay. So I'm going to pass this over to Rena, see, what are your thoughts on the role of a case manager or field care coordinator?
Thanks, Laura. That was a really good intro and description of the transition team. I wanted to just first throw out there if anybody's unfamiliar with what Optum is, because I think a lot of people are kind of unfamiliar with what Optum is. We're the managed care company that is contracted with Medicaid to manage the Idaho Behavioral Health Plan, which is basically any outpatient community mental health services that are offered to people with Medicaid in Idaho. And so a field care coordinator, we're regional licensed clinicians with the Optum clinical team, and we are throughout the whole state. So there's some of us all the way up in Coeur d'Alene and some of us all the way over to Idaho Falls. There's a few of us in every region. And what we do is we bring clinical expertise on all aspects of high risk Medicaid member treatment by working with providers, with the members, with the family, and with stakeholders in the community, stakeholders being like children's mental health, sometimes the probation team. And what we do is we help identify and align available services that are in the community. And then we also can help to facilitate coordinating and collaborating with the treatment team, just regarding service planning. So sometimes when a kiddo is transitioning to a higher level of care and then back into the community, they have already had a case manager with their agency helping them, just to link to services, following their plan of care, making sure that they're getting the right care at the right time with what they need. Sometimes there's not a case manager involved, and field care coordinators, we can get referrals at any time for high risk members with complex needs. We can get referrals from Medicaid, we can get referrals from providers in the community, we can get referrals from parents themselves. But particularly when a youth applies for a psychiatric residential placement with Medicaid, a field care coordinator is automatically assigned to a family, or a referral is given over to us, and we can kind of help on the front end with getting enough support in place while they're going through that process, because as most of you know, that could take a while. So even if they're approved, sometimes it could take a while for a kiddo to get into a psychiatric residential placement. And so we help on that end. And then kind of like children's mental health, when they do go to the facility, a field care coordinator will take a step back. But then again, as they get ready to transition back home, a field care coordinator can come back and involve with the treatment team and kind of help with a smooth transition home, just because we can we're the experts on the local area where the kiddo is coming back to the community, and we know what services are available, so we can educate the team about what service options there are, and kind of meet so if a facility is recommending A, B, and C for treatment, we kind of can come back with, okay, well, this is what's in Idaho, and this is what's the most similar to what you guys are recommending. And we can kind of get the information together for the team so that the parent can make those calls and get those services lined up for when the kiddo does come home. That way we can, guarantee that there's continuity in care and there's not a gap, so that when they come home, their needs are going to get met right away. So
So
we're not exactly, go ahead, Laura, what were you going to
I was going to say, I think it's important to point out that while you can identify the services, you can't force providers to have a spot on their wait list for the kid. You cannot force more providers to just magically start working so that there's, enough providers for the kid. So the limitations you have is identifying the services that exist. And you can be invited by the parent. And if a parent realizes they're in a meeting and that there's a lot of questions being asked about services and no one at the table can answer them, and a field care coordinator is not sitting there, if you're sitting with EPSDT, chances are Francesca and her team have already figured that out and they've got an Optum person who's going to be joining. But if a family
Yes.
has chosen, a family who has Medicaid but has chosen to privately pay for a facility, or has another way or the child with children's mental health payment, or something has happened that is not directly through the EPSDT team, they can still call you and say, hey, I've got a kid coming home. Could you please join these meetings?
Yes, that's exactly where I was going to go next, Laura. So we'll get a referral if it has gone through Medicaid. If it hasn't gone through Medicaid, a field care coordinator is not going to know that this youth is coming home. And so if you did have a field care coordinator ahead of time, go ahead, and I would recommend that parents advocate to bring that field care coordinator back to the table. You can reach out to the field care coordinator. You can give the facility our contact information so that we can be pulled in and we can get a referral. We could start helping the team. And I can put in the chat box, we have right on the Optum website, we have on our contacts page, we have a regional representation flyer, and it has the member line, it has the clinical services phone number that they can call, and it has the field care coordinator's information too. So I'll put that in the chat box. One thing that I think is important to point out is that if a field care coordinator is going to come into the picture, we need at least 30 days prior to the transition so that we can start getting things set up. Or get the information to you guys so that you can get the kiddos on potentially a wait list. I know there's kind of a lot of wait lists, specifically in the last year with COVID. So the earlier that we can start the transition planning and get a plan A and even like a plan B and a plan C if we need, we need enough time to do that. So, and it's also important that I point out that we kind of take the lead from the facility. So they've had the most recent clinical observation and work with the kiddo. So we're going to be relying on what they're recommending as follow-up care so we can make it as smooth as possible of a transition and we can line up the care that the youth needs when they come home. So what we're actually there for is to educate about what's available and educate about the types of services that we have in the community and what kinds of programs. And luckily this year and the last year, we actually do have some partial hospitalization programs and we do have some intensive outpatient programs. Not available in all regions, but most regions there's availability. So the sooner we can get the family and the kiddo connected with those things and lined up before they leave, the smoother the transition will be.
Definitely. So Liza and Melissa, there's a lot of overlap on what we just said for what you guys do. Is there anything unique that we need to point out on the juvenile side, on the correction side?
I guess I would just point out the county probation is an essential part of the puzzle, even at the community placement transition. Because right when the client comes back out from DJC, the baton is passed to them, but they're also involved before commitment. They're just involved if the kid is involved in the juvenile justice system. Probation or county probation is also a big part of that puzzle. So I think they kind of fit in both areas, because you'll see some clients will be in a community placement that will also be on probation. So that's all I would add. Melissa, did you have anything else?
No, I agree with you. I was gonna say the same thing, that probation, they're probably the one player besides the family that has been with the juvenile through that whole process.
So one thing I'd like to point out that isn't on either wheel here is that many families have private insurance, even if they have Medicaid. They have a secondary insurance here as a private insurance. And many private insurance companies have their own internal case managers that you can ask for. So I know in our family, on our transition team, we had our private insurance person who was kind of like a field care coordinator from Optum, but they were focused on what they could pay for on the private insurance side. And so that is someone else that a family can always choose to invite to their team. We had that private insurance provider on the treatment team, the entire treatment placement, the entire time, so that they were familiar with what was going on, and then they could advise about what was available back on, for follow-up care. So anyway, just that's one other person that we haven't really talked about, but if you happen to have private insurance, that is someone else you can invite to that team. So I wanted to, now it's time for us to talk about creating a plan. We've talked about how we get to this process, but what does a plan look like? And this is, it's not a last minute activity. A plan is not something that you throw together with bubble gum and packing tape on the way out the door. This plan is very well thought out. And I wanted to, as we take a look at these questions, we have a lot going on. And Darren, I wanted to throw this to you first. When we're looking at these questions, how important to the success of your patients are the answers to these questions?
It's crucial. If they don't have support, they're going to struggle no matter what. And so right off the bat, you have to look at what family supports they have and then look at the community. And so if they're falling through the cracks, most of the time it's because they don't have a good wraparound of support. That's my thoughts. And so the success is key to support.
So we had a session yesterday where we talked about crisis and safety planning. And one of the things we talked about is a crisis plan should be better named how not to have a crisis plan. And a safety plan is how do you stay safe if you're actually in crisis. Is that always a part of your transition planning out, a crisis and safety plan?
It is. We actually call it a personal recovery plan, really, because there's steps to being safe and to not being in crisis. And so it is an involved process, and we start that process. A lot of places maybe start their crisis planning or safety planning in the last stage, but we start in the first and middle stage, developing this plan along the way with the parents, not just with the child. So.
Well, and you mentioned family having, being wrapped with services or support. And I think it's important for us to note that one of the things that exists in Idaho, there is frequently a wait time for it, is wraparound, which is, if people who are involved in wraparound will tell you, has a capital W, as opposed to the concept of wraparound, which does not. Capital W wraparound is a formal process that has a very formal set of facilitated events and trainings and meetings behind it. And that's something that if families are interested in, is something that comes currently through the Children's Mental Health Program. And that's someone else that you might want at your team earlier as opposed to later, if that's something that you were doing. But I think the question is, if the transition plan is stuff the family can't do, it's not going to be successful. So it's not just the availability of services, but if the transition plan is that you're going to drive your kid 2 hours to and from treatment every day, but the family doesn't have a car, it doesn't matter how great that treatment was going to be if they can't get there. And so I think that those things need to be taken into consideration all the time. Francesca, I know this is something you asked, I know these questions because you helped me ask them. So tell me what it looks like on the EPSDT side.
So I think one thing to point out here is just looking at this path, is just how important it is to communicate and collaborate here, because nothing within this path can be done by one group or one person. So it really does take a village. And I think for the families that we work with, one responsibility that my team takes on is helping the families to know what to ask, who to ask, when to ask, right? All of that kind of processing of like, I don't really know where to start. Okay, well, let us help you out. Let us see who's been involved. Let's try to pull some folks in. Let's get a meeting scheduled, whatever it is, just to provide more clarity to what's going on and where we're all trying to go. Because EPSDT works with the majority of PRTFs are out of the state of Idaho. So they all have different processes. They all have different kind of expectations that they set for their youth and the families that they're working with. Of course, Medicaid has particular standards that we expect them to work within, but we all know how hard that can be with holding folks accountable. And yeah, I digress.
And we love you,
Um,
Darren.
Darren, I mean, that's the thing is the out of state facilities, we have some fantastic ones we work with that are very willing to be collaborative and, you know, others that need a little bit more push, a little bit more of a nudge of, hey, we need you to help us out with this. And I think, again, that's where my team takes on that responsibility of helping the families out with knowing like when is it appropriate to push for more help. You know, we can't do it all, but we can definitely do enough to help shed some more light on how we need to work together and what we need to do to support a family so that a transition plan, like I said earlier, is successful, not just there, right?
Well, I do have to say that the trust that's built within these teams happens over time. And I was surprised when my own son called me one day and he was upset about something happening at the facility. And he requested that his EPSDT team member join him for a meeting with facility staff. And, you know, he was a teenager and he's like, I feel like I need my Medicaid rep with me to have this conversation. And she got on the phone and they did a conference call and he advocated him for himself. But he was so sure that his team that had been working for this process the whole time had his back that he called them in for a conversation he wasn't sure how to have. And at that moment, I'm like, okay, so this teaming thing is like really working. I was so proud of him. And the feedback I got, he didn't even want me there. He's like, no, Mom, I got this. I just need my Medicaid backup. and I think that teaming, we're teaching our youth what we want to see through this process. You're not having to do this alone. You have an entire group of people who is here to support you. What does that look like? So, I want to give IDJC a minute to talk about, how do you guys answer these questions a little bit differently than a standard psychiatric facility?
I can just jump in for the community piece of it, and then maybe Melissa could focus a little bit more in. I guess my biggest takeaway that I would want to share is flexibility and being flexible with funding. We have certain rules around funding. Federal guidelines mandate certain things, or the state, code or whatever it may be mandates some of the funding rules and how we can spend it. And I think it's just really important to be flexible based on the needs of the family and the client and providing that funding or that money to support the resources for them. And so that would be my biggest thing to provide you guys as a group.
Yeah, and I do think there's some similarities with DJC and what's been discussed. Again, that collaborative process involving the family from the very beginning. I think also the JSC is, again, that vital player who is working closely with the family. And if there is a crisis in place when a kid is in custody, the JSC is involved with probation. During that same time, during the transition, the JSC is working with the JPO and the family, maybe even going into the homes and talking about any possible barriers there may be. And if there are, trying to problem solve those barriers. The goal, obviously these kids have formal supports within our system, but we also want to make sure they develop some informal supports as well during that transition phase. So again, some similarities, but I think we do some things a little different as well.
Well, I think DJC, because you hand off to probation, you have a very formal structure after they leave your facility to make sure that, the support plan is happening. When they leave a residential facility, like, the Darren works for, his staff isn't following them around. And
Right.
So there's a little bit of a hard break. And interestingly enough, and we're going to end with Optum here and Rena, but you guys are one of the people who actually do continue with families after they leave a case. You can follow that. So talk a little bit about how you make that transition smoother.
Yeah, that was actually one other point I wanted to touch on, Laura, was that as the youth comes home, we can continue to work with the treatment team. We can continue to work with the family. We can connect with the providers and the treatment team and schedule some multidisciplinary team meetings, just so we can make sure that everything's on track. And if we need to make changes to the service plan, or, maybe things come up and we're needing to meet the family's needs in a different way, then we can continue to monitor the child and work with the family and the treatment team to make any necessary changes until everybody feels like they're in a stable place, that they're, in a baseline and maintaining. So we can offer support for a while after they're home. So I guess it can kind of meet the need that way.
I think you can. Well, we are at time, and we could probably all talk about this for another solid hour if we had more time, because there's so much to talk about and there's so much happening with transition. But as a parent, I would leave it with stay involved. You've got a lot of people who have letters at the end of their name sitting at a table, and you may feel a little overwhelmed by that, but stay engaged, stay involved. And if you take a moment to engage in the transition process, for me personally, not feeling like I had to defend the right for them to be there, that I wasn't struggling against a discharge, I was looking towards a transition, that helped me engage in a more proactive and productive fashion than feeling very defensive. So obviously it's not always perfect, it's not always everything we'd always imagine, but there's a lot of good people doing a lot of good work to help our kids come home back to the community and transition safely and appropriately. So thank you to each of these panelists. I can't even begin to tell you how much I appreciate their work and their effort and their collaboration actually to even get us to this presentation. This is not a group of people who traditionally talk to each other in this format about how our processes go. So bringing this knowledge to one place is a really big deal. So thank you guys all for joining us. I can't begin to thank you enough. And I know that the parents who are watching now and who will watch the recording of this later will greatly benefit from the knowledge we just shared today. So thank you all. And I guess we'll see everyone in the next Parent Network session in a little bit.
Awesome.
guys.
Thanks so much.
Thank
Thank
you.
you.